Thank you, Guillermo. Good morning, everybody. Welcome to the Diabetes Symposium. I'll be kicking off the day with a talk on oral agents and non-insulin injectables. No conflict of interest. We're going to address concepts and management principles. It's a very broad topic this morning. And so I suggest that if you hear something that you want to further investigate or something that reinforces what you're already doing or something that you feel may be controversial or not what you're currently doing or disagree with, to look to do a deeper dive. I'll give some references here at the end as well. Our learning objectives today are to review briefly the multifactorial pathophysiology of type 2 diabetes and targets of treatment, pharmacologic options currently available with some emphasis on new agents, the approach to individualized pharmacotherapy for our patients, and review some of the novel paradigms that would for management of type 2 diabetes. Before we get started, I just want to make a comment generally about the physician-patient relationship and patient success with managing diabetes. I do actually use this analogy with my patients. It's important for them to understand that they're really managing their diabetes. We're the coaches on the sidelines. They see us intermittently through their course. We help make management decisions and put fires out and guide them for success with their blood sugar control and their cardiovascular risk reduction. But they really need to understand what the goals are and how to get there. And so I think it's critical that all patients get at least some exposure to diabetes education so that they understand what to do and how to address issues as they arise and when to notify us if there are problems. So that's key. And without this as a foundation, it's going to be much harder to get things done. When you sit down with your patient, you want to be sure that you are dealing with type 2 diabetes. The idea here with these oral agents and non-insulin injectables is that we try to spare insulin dosing, and the reason being is that insulin, which you'll hear about later from one of my colleagues, and insulin's certainly a good thing, but insulin does increase the risk of hypoglycemia. Insulin is associated with weight gain. And so if with some of our newer agents we're able to shift patients off of insulin and provide perhaps control without the same risk of hypoglycemia and spare some insulin dosing and weight, then we'll do so. But if you've got a patient who's clinically type 1, this is not going to be successful. So even if someone is billed as a type 2 patient, you want to look at your first visit and assess them clinically and say, well, does this patient look like perhaps they're type 1? Even if the patient has been diagnosed with type 2 and is clearly type 2, but has had type 2 diabetes for a very long time, their insulin reserves will be diminished, and they may need insulin regardless. If a patient's habitus is suggestive of type 1 diabetes, if a patient's insulin requirements are low, these would be hints that perhaps you're dealing with a type 1 patient. Glycemic variability. Do blood sugars go sky high after eating meals? I have a patient as a father of a childhood friend of mine. He's in his 90s. If he doesn't get insulin before his meal, his blood sugar goes into the 300s and 400s. He needs insulin for meals. That's okay. Whether he's billed as type 2 or not, he's clinically acting like a type 1 patient. At his meals, he needs insulin. We can look further into this. We can check C-peptide. You want to interpret that with the blood sugar. We can check type 1 antibodies to assess latent autoimmune diabetes of adulthood. This is a type 1 process that is a more prolonged course with patients potentially going without insulin for a long time. But the bottom line is, if a patient looks clinically to you like they're a type 1 patient, then in all likelihood they're going to need to be treated that way, and getting them off insulin completely may not work. So it's okay if patients need insulin, and you just want to make that judgment when you start, and then as you progress if you're noting problems. When we think of type 2 diabetes, we understand that there are multiple contributors to blood sugar, hyperglycemia, insulin resistance, all of these things. Note that, and apparently I can't use a pointer here, so we'll just talk through it. By definition, if a patient presents with hyperglycemia, that patient has insulin deficiency. Up to that point, whether the patient has weight gain and is aging, the beta cells, if the blood sugar is normal, the beta cells have kept up and the blood sugar is compensated. As soon as the blood sugar goes up, by definition, that patient has an insulin deficiency as part of that, the pathophysiology. There's insulin resistance at skeletal muscle. There's insulin resistance at the liver. I don't know that a week goes by without a patient asking me, how come I go to bed with a sugar of 90, but I wake up in the 150s? And the answer is the liver. So we address each of these areas with different drugs. The gut, insulin resistance at the fat, our newest agents that work at the kidney. So when we sit down and we put together a treatment plan, we want to have our goals in mind. One goal to consider is the hemoglobin A1C. I'll make a couple of comments about that generally. One is, this is not a perfect measure, it's an average. And I try to explain this to patients, and literally blood sugars of 0 and 200 will give you an average of 100 and look good, but we know that the day-to-day control is poor. The A1C is not a perfect measure in and of itself. Things that can impact it would be transfusions of blood of red cells, erythropoietin therapy. If a patient's A1C drops from 9 to 7% after erythropoietin, it's not the blood sugar control, it's the erythropoietin. So things like erythropoietin, IV iron, things that shift the red cell population to the younger side will spuriously lower the A1C. End-stage liver disease, end-stage renal disease, hemoglobinopathies will impact the A1C, and there's population variability as well. Caucasians will have a lower hemoglobin A1C for the same blood sugar. So with respect to goals, we're really looking to individualize them. The societies still have published their guidelines, and I've listed them here. They do put caveats in. So, for example, ADA, American Diabetes Association, for older adults, you may want to cut back and run the A1C a little bit higher. AACE, also the Endocrine Society, the American Association of Clinical Endocrinologists, also suggests individualization, and we'll look at this, but longevity, cardiovascular risk factors, things that increase risk of hypoglycemia will impact your decision making with respect to goal A1C. The American College of Physicians has a looser goal, 7 to 8% quote in most, but again, we personalize this. Our paradigm for blood sugar control and for outcomes is changing. There have been multiple trials over the years looking at blood sugar control and its impact on microvascular, macrovascular, or vascular disease. And the take-home message here is that it's much easier to show benefit for microvascular disease than it is for vascular disease, macrovascular disease, heart disease, heart failure, stroke. And the reason is that glycemic control drives primarily the microvascular risk. There's some evidence that it can help impact macrovascular disease, but it's much harder to show. We're shifting away from a glycemia or glucose-centric tight control as rigid rules. We individualize our goals now based on things like patient comorbidities, longevity, and weighing the risk of hypoglycemia over time for the long-term benefit of microvascular disease. And now we're going to start using some of our newer agents to get not only blood sugar control, but the non-glycemic benefits, which are cardiovascular, renal reduction as well. This is a quick snapshot of the UKPDS data, and I'll point out on the left that they were able to keep the A1Cs separate from the intensive control group and the standard control group. That way they were able to look at differences in effect, but note that everyone's A1C in both groups got worse over time progressively. And note that they were able to show microvascular benefit with an average difference between the two groups of 7.9 versus 7.0. So all the benefits you see here on the right are from an average difference of less than 1% A1C between the quote tight control and the quote standard control. Having said that, obviously you can see that the A1Cs were higher than we might want generally. This is a type of chart we now use to think about risks and benefits of tight blood sugar control. So what we want to know is the benefit of long-term microvascular risk reduction worth the increased risk of hypoglycemia? And the answer is that on the left side of this spectrum here, where there's low risk of hypoglycemia, early or newly diagnosed disease, long life expectancy, and so on, these patients have a long way to go. And so we would consider trying for tighter control because the benefits there are higher. On the right side here, we've got patients with who are older and have macrovascular disease and are much higher risk for and from hypoglycemia. And so we would consider less stringent control so that we maximize benefit and risk ratio. So if it were me, for instance, and I was younger than I am now, and I fall to the left of this spectrum, then I might argue that given in our trials, it appears that at least in most episodes, most instances, that there is no threshold for glycemic benefit. In other words, the lower the A1C, the better, at least for microvascular risk. Then I would say that the lower the A1C, the better. And let's use our newer agents that really have much lower risk of hypoglycemia and also reduce cardiovascular risk. So my A1C is 6.5 and I'm newly diagnosed 42-year-old patient who's overweight, then I'd like to see it a little bit lower, and I can add agents on that will not inordinately increase my risk of hypoglycemia. So what do we consider when choosing our agents? First, our goal A1C, at least from a glycemic goal standpoint, and that's what we just discussed. What are our comorbidities? What's our longevity? How long do we have to go so that we can try to get some benefit from the microvascular risk reduction from our therapy without increasing the risk of hypoglycemia? The risk of hypoglycemia is not just the risk of it occurring, but it's the risk from hypoglycemia. So if you've got someone who is at high fall risk, for instance, that should play into your decision making, because not only would that patient, if the risk is higher based on the agents you're using, insulin or sulfonylureas that we'll get to, if that patient were to have an episode of hypoglycemia, then that patient would be at higher risk for perhaps from a fall, or perhaps the patient's in a nursing home and would be unable to express symptoms of hypoglycemia to the staff to get treated. Think about weight benefits. Do we want to use agents that help prevent weight gain while lowering the blood sugar? I think the answer is yes. Think about the cost of the agents you choose. These days, that's as important as it was, as important as it's ever been. And then when we start thinking about our newer agents, and you're going to hear about this from my colleague later this morning, let's think about the cardiovascular benefits that we derive from some of our newer agents. These are non-glycemic benefits. So in other words, in trials, these agents showed reduction in cardiovascular risk independent of blood sugar control. So heart disease, heart failure, potentially stroke, and actually now with new data, protection of the kidney, so prevention of progression of nephropathy. Think about your side effect profiles, think about precautions in each of your patients, and think about contraindications. When I was a fellow, we had literally two options. Human insulins, none of the analogs were available at that time. They started to appear when I was a fellow. Lispro came to the US when I was a fellow, and sulfonylureas. In fact, metformin came to the US in 1995 when I was a fellow, and that was a huge deal. Its cousin, another biguanide, fenformin, had been taken off the market after one of the earlier trials we looked at on the previous slide, the University Group Diabetes Program, with concern about cardiovascular risk. And so Europe was using metformin for decades until it came back to the United States in the mid-90s. So here we have a list of today's options, which is quite extensive and gives us a better chance to pick something that's going to work nicely for each individual patient. We'll go through each of these groups, and we're not going to be able to do a tremendously deep dive into any of them, but I would encourage you to look into things that you hear about that you may want to explore further. And I think someone needs to mute if possible on the back end here. Thanks. Note at the very bottom right, we've got now an oral GLP-1 receptor agonist. That's new. It's not injectable. It's semaglutide, which previously was a weekly injectable, is now available as an oral agent, and I've added it down here. I'll also note that though we may not be as aware or use them as much, we've got some options here like quick-release bromocriptine and colacevolin, both of which have been approved by the FDA for treatment of type 2 diabetes. So those were our oral agents. It's a pretty big list. Here's our list of injectables, and it's also a pretty big list. I'll note here, and we'll come back to this, but we've got our GLP-1 injectables, some combinations that are available on the market now in our amylin analogs. And comment briefly that dulaglutide now has 2 additional dose ranges. This is within the last few months. It's now available as a 3.0 and a 4.5 milligram weekly injection, whereas previously it was a 0.75 and a 1.5. Keep in mind that depending on the class of agent you choose or the individual agent, there will be a difference in its onset and its absolute lowering of A1C. And you want to think about that when you're starting off. So if someone's A1C is close to goal and you don't need to lower it beyond, let's say, 1 additional unit, then you can use 1%. You can consider something like acarbose, whereas sulfonylureas will drop it much further. Here you see thiazolidinediones on the bottom right. They drop the A1C as well, but at a slightly slower pace. You can estimate that each oral agent will give you about a 1% reduction in A1C. There's some exceptions, for instance, acarbose or the meglitinides, which will lower it slightly less. So metformin, this is still considered first-line therapy. The guidelines recommend that we start it at diagnosis with lifestyle modification rather than giving lifestyle modification a 6-month chance as it previously had been. We want everyone to work on diet and exercise, and it's wonderful if they're successful, but it's hard to do. And we know that if we start pharmacotherapy up front with diet and exercise, we'll be more successful. It'll lower the A1C a percentage or more. It's got a good response rate. It's cheap. I'd consider it weight neutral. It has some lipid effects, and metformin was shown in the UK PDS trial to have some macrovascular benefit. It showed reduction in MI in a sub-study of patients in the UK PDS who were overweight. You can see GI side effects. The risk of lactic acidosis is extraordinarily rare as long as it's used in patients who don't have severe renal insufficiency, and you want to avoid using it in patients whose GFR is less than 30 or for patients who have decompensated congestive heart failure. Rather than going through this whole thing, the answer is for when you start metformin, start low, go slow. There's no emergency to get to 2,000 milligrams a day. And I promise you, if you start at that dose, the patients are going to have side effects, and stop it. Start at 1 pill a day and slowly increase. The newest guidelines allow us to continue but cut back on the dose at 45 mils per minute, and we should not start it at the lower GFRs. Below 30 is still technically would be considered contraindication. We'll move on to the sulfonylureas. The sulfonylureas are older agents. We know on the left side here that when you give a sulfonylurea agent to a patient, it lowers the blood sugar, and on the right, it does it by increasing insulin release. This is glucose-independent insulin release, and we're going to come back to that. That's a key point. It increases insulin secretion from the beta cell. It'll drop your A1C 1%, 2% or more. There's a good response rate. It's relatively immediate. It's low cost or cheap. It's potentially once daily dosing. For that reason, they're still used frequently. This is a cartoon to show you the sulfonylurea receptor on the beta cell. It's on the top right, labeled SU. That's an ATP-gated potassium channel. Sulfonylureas gate that channel and allow for depolarization of the beta cell and insulin release or insulin secretion. If you look to the right, that's the receptor. If you look to the left, that's the beta cell's normal process, top left glucose leading to ATP, which then gates that channel. Guess what? Sulfonylureas short circuit that pathway. The beta cell no longer cares what the blood sugar is. It's going to continue to secrete insulin as long as there's sulfonylurea on board. So they can cause significant or severe hypoglycemia. They can cause weight gain. Their metabolites are hepatic and cleared by the kidneys. And so if you've got a patient with renal insufficiency, they're at a much higher risk for hypoglycemia. They may do well long term. They may run an A1C of 6.5 or 7 on sulfonylureas and not have a problem for some period of time. But what happens is they develop an intercurrent illness. They stop eating, and the sugar can drop, or they can have progressive renal disease, or as the A1C comes down, they need less drug and they get into trouble. So we really try to avoid these agents in patients with kidney disease for sure. There's some question as to, let's say there's some controversy in the literature as to whether there's cardiovascular risk or not. This dates back to the UGDP, that original trial on our slide that we showed. Sulfonylureas actually from that trial got a black box saying that they cause cardiovascular injury. The mechanism is via the sulfonylurea receptor in the heart. In fact, it was first described in the heart. It's in the heart, the sulfonylurea receptor is involved in something called ischemic preconditioning, which protects the heart muscle from recurrent ischemic events. And when we interfere with that with sulfonylureas, the theory is we're causing trouble. Glimepiride potentially has less of an impact on sulfonylurea, induces ischemic preconditioning. One note here is that in the patient who comes in with renal insufficiency and has refractory hypoglycemia from sulfonylurea, you can use octreotide, which is an off-label use, but will work to shut insulin off while you're waiting for the patient to recover. And these sulfonylureas, particularly when patients come in with severe hypoglycemia and renal insufficiency, the hypoglycemia can last for the sulfonylurea effect can last for quite some time. So they've got some issues, hypoglycemia, potential cardiovascular, and nevertheless, they're very inexpensive and they work. So as you see here, they are continued, they're still used frequently in this country. Thiazolidinediones, essentially this is pioglitazone. These drugs work by acting at PPAR gamma, which reduces insulin resistance. Peripherally, they'll lower the A1C 1 to 2%. They shouldn't cause hypoglycemia alone, but if they're used with sulfonylurea or obviously insulin, they can increase the risk of hypoglycemia for the reason we just looked at the beta cell. They don't cost much these days. Once daily dosing, there's some evidence of cardiovascular protection. There's weight gain with these drugs, but it's not the central or intra-abdominal weight, insulin-resistant weight gain. They take a little longer to act. There is acutely the risk of edema and heart failure in patients who have a history of congestive heart failure, reduced ejection fraction, so we want to avoid them there. They can have negative impact on bone density, so you want to follow that. There may be there is likely a potentially very, very small risk of increased bladder cancer. I personally follow UAs on all my patients and review this with them. And there's some controversy, but probably the answer is avoid them in patients with macular edema. There are some additional agents that we can review quickly. The meglitinides, these agents act at the sulfonylurea receptor, but just think of it as having a slightly different affinity. They have, therefore, a much shorter half-life at the receptor and don't hang around to cause hypoglycemia. They may be better choices, or they are better choices if there's some renal insufficiency potentially. One can take them with meals. One can skip the dose if one skips the meal. Alpha-glucosidase inhibitors inhibit or slow carbohydrate absorption at the gut. Dopamine agonists, which is quick-release bromocriptine, it impacts it mitigates insulin resistance related to not circadian rhythm, but we'll move. I'm blanking on the term I'm looking for, but and then bile acid sequestrants, which will also lower blood sugar and are approved by the FDA for blood sugar control. For diabetes, they will raise triglycerides, so you need to keep that in mind if you're using them. So getting to the GLP-1 axis, this is addressing what is the incretin effect. And normally, it turns out that insulin release is its primary driver is macronutrients or carbohydrate in the gut, not the blood sugar. And so in type 2 diabetes, this effect is blunted. And if we replace this gut hormone, we can impact insulin release and improve blood sugars, including post-meal blood sugars in our type 2 patients. Importantly, this is a glucose-dependent mechanism, and we'll look at that in a sec. These agents also inhibit postprandial glucagon. These agents slow gastric emptying, so patients feel full and will lose weight in that respect. They also suppress appetite, which will contribute to weight loss. Here's what glucose-dependent insulin secretion looks like. If you look at the left, there's your glucose. It's coming in and it leads into the beta cell, leads to ATP generation. That gates the sulfonylurea receptor. And so as the glucose rises, you have that same process on the right, which is depolarization and insulin secretion. As the glucose levels go down, let's say after a meal, the ATP therefore drops, and the insulin release decreases. That's how we avoid hypoglycemia. The GLP-1 augments that process, but it's still glucose dependent. So if there's no glucose to augment, then the insulin release, the insulin secretion will diminish, and so you don't have the same issue with hypoglycemia because the insulin release is still glucose dependent, even though the GLP-1 agonist is augmenting the process. Note, however, that if it is used in combination with the sulfonylurea, for instance, then you've got the same problem, which is that sulfonylurea has short-circuited this, and the cell no longer cares what the blood sugar is. It's going to continue to secrete insulin. So how do we address the GLP-1 axis? The first agents are DPP-4 inhibitors. These agents inhibit an enzyme that breaks down our own endogenous GLP-1. You get more of a GLP-1 effect, but the levels that are achieved are much lower compared to the injectables. They're essentially weight neutral. If used alone or with agents that don't cause hypoglycemia, they don't contribute to that. There's no problem with heart failure or kidney disease. Cost is an issue, but because the GLP-1 receptor agonist injectables give us much higher levels, they are the ones that are associated with better outcomes with respect to weight. This all started with the molecule that came from the Gila monster, leading to the first GLP-1 analog, exenatide. We now have multiple GLP-1 receptor agonists to use. Some are daily and some are weekly. And as we noted, now there's an oral agent, semaglutide. It's both injectable and now available as an oral agent. These agents, in addition to lowering A1C, also show reduction in body weight. This one is early data for exenatide. This next one is liraglutide, which is a daily injectable. All these agents have several dose ranges. You always start off at the lowest dose and slowly titrate up. If you start them at the high dose, you're going to have a patient with nausea, vomiting, and they're not going to want to start the medication again. So you always start at the low dose, give them time, a few weeks between, and then slowly titrate up. So here's data from liraglutide comparing blood sugar control to placebo, as well as other agents. Here's change in body weight with liraglutide. In fact, liraglutide is available as 2 brands, one going up to 3 milligrams approved by the FDA for weight loss, independent of whether the patient has diabetes or not. And that's because these agents, as we discussed, slow gastric emptying, patients have earlier satiety, they feel full earlier, and it suppresses appetite. So you can still have gastrointestinal problems, even if you do the best you can to slowly increase the dose over the dose range. All are injectable still, except for the oral semaglutide. They all are associated with slowed gastric emptying and appetite suppression, so you see weight loss with them. They have the glucose-dependent insulin release and suppression of glucagon. They work nicely. We are mandated to note that they are contraindicated in patients with a history of pancreatitis or a personal or family history of medullary thyroid cancer or MEN2. They are costly, and one comment I'll make here is that when you start these agents, you have to let the patients know that they have to keep track of their bowel movements. They can slowly start to get constipated, and I've had a couple of patients who got into some trouble with somewhat of a functional ileus type picture. So make sure that you check with the patients when you see them that they're having daily bowel movements if they let you know if that's not the case. The last agent we'll discuss is the SGLT2 inhibitors. These agents work by inhibiting the reuptake of glucose in the kidney, and so the patient loses glucose in the urine. This lowers the blood sugar and is associated with some other very positive effects that you'll hear more about later from my colleague with respect to cardiovascular risk, but we'll go through a little bit of it here now. There are 4 agents currently approved. These agents, through the loss of glucose in the urine, reduce your A1C. They reduce fasting and postprandial glucose. It's an insulin-independent mechanism, so this is not directly impacting the beta cell. You're losing glucose in the urine, and this is what's lowering your blood sugar. If they're used alone or with agents that don't cause hypoglycemia, then the risk of hypoglycemia is very low. But as you've seen in the commercials, for the reasons we just discussed, if you're on sulfonylurea, you're going to be at higher risk with any agent that you add to it. Same with insulin. So you need to think about this with any agent you add to either sulfonylurea or insulin. If you're going to add them, it's going to depend on what your A1C is. But if you're starting off with tight control and you're looking for, let's say, for cardiovascular benefit and adding one of these agents, you're going to need to back off on these sulfonylurea and or insulin. If you're starting with an A1C of 9, perhaps you won't need to because you're adding an agent that should drop it the A1C a percentage. There is some weight loss and blood pressure improvement. We'll talk about cardiovascular protection and kidney protection with these agents. It's been a game changer with respect to how we approach management of diabetes. We're no longer just thinking about blood sugar control. What we're thinking about is blood sugar control, but as well, we're thinking to reduce our patients' cardiovascular risk and risk of prevention of kidney disease. These agents work well as monotherapy, but nothing is perfect. This is a little bit of a tough discussion to have with the patient, but I always start off by explaining that the point here is that the benefits outweigh the risks in their case. If I've already assessed their risk benefit, and I wouldn't recommend it if I didn't feel that weren't the case. Having said that, it's key that you let the patients know several things, clinically and medically legally. Because there's now sugar in the urine, these patients are at increased risk for urogenital candidiasis and at the extreme soft tissue infection. Urinary tract infections, vaginitis. These patients do cause volume depletion, and there is going to be some bump in the creatinine, potentially transient, but in patients who are on loop diuretics, which may be a lot of these patients, one has to be careful and watching the creatinine and making sure that the patients don't have acute kidney injury. There's recent publication a few months ago showing that at least in patients who start off relatively stable, that even within a matter of days, some of these patients will need their loop diuretics cut back by 50%. Because they're having increased diuresis or increased urine output from these agents. Orthostatic hypotension is a problem. There was concern initially about lower extremity amputation. It wasn't clear what the mechanism was. There's some reassurance in trials like Credence that this is not the case, but I warn patients about this, plus they're going to see it on television. Post-marketing, patients were calling with illness, and when asked what their blood sugar was, they'd say, well, it's 140, and it was not initially recognized that these agents put patients at risk for normoglycemic or euglycemic DKA. So if you've got a patient who's ill, you need to consider DKA regardless of the blood sugar. They're losing sugar in their urine, so the sugar doesn't go up. It's for this reason that we hold these agents preoperatively, somewhere between 3 and 14 days. if they go into DKA on these agents post-op, the ketoacidosis can last for days or longer. There's risk of hypoglycemia in concert with sulfonylureas and insulin, and they can be costly. Because these agents have a increased glucagon, there's this higher risk of DKA, and so you don't want patients going on ketogenic diets on these agents. In fact, the FDA put that as a label onto these drugs, and I had a patient who literally, I think a week after that came out, had been started on one of these agents and essentially cut all of his carbs out, and he wound up in DKA a week after starting. Because you've got to watch these patients carefully particularly in the setting of patients on loop diuretics. I always have these patients recheck their labs 1 to 2 weeks after starting to make sure that their creatinine is staying where it belongs. The agents probably don't work as well once the GFR drops too low, and it increases the risk of problems if they're started with a GFR that's at a lower GFR. So you need to review the GFR cutoffs for these agents. They vary slightly. The current trials and consensus guidelines are starting to allow us to go lower, 45, 30, but that doesn't mean that that's on label. You'll hear more about that, I think, later this morning. We know the glycemic control declines over time with monotherapy. On the left is metformin, on the right sulfonylurea. Diabetes is a progressive disease, and these agents' impact won't last forever. In addition, we know that these agents will probably give us a 1% reduction in A1C. So if we're starting with an A1C of 10 or 12, we're thinking insulin, but we know that with single agent won't get us there. Perhaps we're better starting with 2. If we do add, it's just that we add agents. We don't switch them. Here's an older slide showing that if you switch glyburide and metformin, the A1C stays the same. You have to add one agent to the other to continue to get the A1C improvement. There's several of these algorithms out there. This is an ADA algorithm showing how to kind of go through progressive or intensification of the patient's regimen. If we start with metformin as monotherapy, then we want to decide based on risk factors and our desire to improve cardiovascular outcome with our patients or renal outcome, which agent to select next. And we'll close by going through what's really now a new paradigm in our management of these patients, and that is that it's the multiple trials now for GLP-1 receptor agonists and SGLT2 inhibitors are showing cardiovascular risk reduction and kidney protection independent of blood sugar control. The initial data was with liraglutide and empagliflozin. They got the first 2 indications from the FDA, and several agents have followed. So I've listed them here on the right, but all of these agents now are approved for some form of heart failure or cardiovascular risk reduction in our diabetes patients. In fact, dapagliflozin has an indication now. Essentially, it's a cardiac drug indication to prevent or to reduce cardiovascular risk, heart failure in patients with or without diabetes. This is worth looking at some point after this discussion. This is the expert consensus decision from the American College of Cardiology. It was endorsed by the American Diabetes Association, published in JACC. And what it's basically looking at is how to use these new agents to reduce cardiovascular risk. SGLT2 inhibitors and GLP-1 receptor agonists, the cardiologists are going to start incorporating these agents into their management programs and or ask us to do it, and it's going to be key that we coordinate with them. There'll be need. So key points here are, number one, them helping us with the diuretics. If we start these agents, we need collaboration with our cardiologists to help adjust the loop diuretics without, we don't want to go too high or too low. We don't want the patient coming in with AKI. We don't want the patient coming in with worsening heart failure. They need our help probably with respect to adjusting insulin. So patients will need less insulin, and we're helping in that respect. We need to follow these patients very closely, blood sugar and labs as well as clinically. And then lastly, the FDA there is now readdressing how they look for safety in clinical trials. There was a big push initially for cardiovascular safety, and now they're looking to expand that to look into other, to pull in other groups, more patients with different age, different comorbidities, to really get a better understanding of what the risks are in the real world for agents that are going to be approved moving forward. And with that, I will end and I think turn it over to the insulin talk. Thank you for your attention.